Thank you very much for joining us today. I'm John Ryan, the CEO of Penington Institute, and I wanted to thank you all for joining us. I also wanted to start by acknowledging that I'm on the stolen lands of the Wurundjeri people of the Kulin Nation. And, you know, this is a big week for Penington Institute in the sense that it's the week that we release Australia's annual overdose report, and it's also the week of International Overdose Awareness Day, which I'm sure many people are participating in one way or another in Australia. And as you would know, it's something that goes around the world now. It started in Melbourne at the Salvation Army Needle and Syringe program in St Kilda 20 years ago. And this year again, President Biden's proclaimed Overdose Awareness Week with Overdose Awareness Day. You know, that's a kind of a good thing in a sense, which is it's an issue that's got some level of traction, but I'm very conscious myself and from talking to people in our field that overdose is something that takes an incredible toll, and it's not really reflected in our annual overdose report. That there are a bunch of numbers in the end, but it's the human stories behind those numbers which is the real motivator for us to do this work, and I'm sure the motivator for many of you. And I just also wanted to acknowledge the toll that overdose causes to frontline workers, many of whom are on line today. The friends and families of people who've been lost to overdose are many more people affected by overdose, by fatal overdose than what the report that we'll talk about today reflects. And I think it's definitely an important area of work. You know, we think of the overdose toll as the sort of tip of the iceberg of problems in relation to overdose. We started doing the overdose report because of that old cliche, if you don't count it, it doesn't exist. And because of our connections with especially people facing drug use issues and workers on the front line, we were aware that the overdose toll was very significant, but not getting the attention it deserved. That's the genesis of the overdose report. We don't do it just to generate another report. We do it because we want to call attention to this issue, and we actually really want to see governments step up and create a framework to actually prevent overdoses. We've got it towards zero for the road toll. The overdose toll is double the road toll now. And so I think in my view, we should have it towards zero for overdose deaths as well in Australia. We're a long way from that, but hopefully with persistence comes the sort of changes that we need. I do really want to also acknowledge Penington Institute staff that put an enormous amount of blood, sweat and tears into the overdose report, including Rafaela, who's speaking today. But there's a very small team, but a whole team of people behind this work that is mostly, behind its desk jockey work. It doesn't get the public acknowledgement that it deserves. So a big sort of shout out of thanks to the Penington Institute team. In terms of the format for today, it's going to be two speakers, Dr. Marianne Jauncey, the Medical Director of the Medically Supervised Injecting Centre in King's Cross in Sydney, followed by Penington Institute colleague Rafaela Caltabiano, talking more specifically about some of the details in the report. And then we'll follow that up with a bit of an interactive Q&A session if people have got questions. We've already had actually some questions sent to us in advance, so my expectation is that we will get lots of questions and comments in the chat box. And I think the chat box is the place to put those questions and comments rather than the sort of hands up icon or whatever. So if you can put your questions whenever you like, or comments whatever you like in the chat box, sorted through. And I've just totally lost all power.
This is not what you want to happen, John.
I'm good. I am still there, but I'm completely.
We can hear you, but we can't see you.
Well, that's probably the best outcome. Can I then maybe just, whilst I'm invisible for some reason, maybe just kick on and introduce Marianne Jauncey. And I would really like to say thanks to Marianne for agreeing to speak today. Marianne's a public health physician. I'm sure everyone online knows of Marianne's work in terms of leading the injecting room for a number of years now. Also undertaking a lot of kind of community engagement and advocacy work around drug policy issues. And so I think fair to say a medico with an enormous heart and an enormous capacity to sort of communicate difficult issues to the broader community and to call for the sorts of sensible reforms that we really need in Australia. So whilst I'm invisible, Marianne, I can I just hand to you for your comments? Thanks.
Thank you, John. It's a pleasure to be here. And let's just see if, 5 minutes in, I turn invisible as well. Maybe there's a gremlin in the system. I'm looking forward to it. Thanks, John. And I'd like to acknowledge that where I'm recording from is Gadigal land in Sydney, and acknowledge that this is stolen land and that sovereignty was never ceded. So every year, Penington produces what should be, in my view, a wake-up call for communities and governments all around Australia. Should be, but isn't necessarily. And I really like, John, your point about this is not a report for report's sake. This is not a bunch of researchers trying to get something in the published literature and increase their kind of standing in terms of impact factor from pure publication. This is an organisation and a report that is designed and created in order to create positive change, and I heartily endorse that. Because this year is no different in terms of the figures. Drug overdose deaths are high. Drug overdose deaths are too high. Drug overdose deaths have been too high for too long, and drug overdose deaths continue to increase. What part of that is not calling out for something different to be done? So the report, and Raf will be taking us through, I'm sure, some of the statistics, but for me, having an early read of the report, drug overdose is in the top 3 leading causes of death for males and for females in the prime of their life in Australia, between the ages of 30 and 50. That is extraordinary. Opioids still take out the top spot, followed by benzos, and then, interestingly, stimulants. And stimulant-related deaths have gone up tenfold in 20 years, and that's more than just an increase in use. Something is going on there. So some of the things that really stood out to me, many of which aren't surprising. We've predominantly got overdoses occurring in men for all but the very kind of, much higher age groups. Shouldn't be a surprise. We know that. We're seeing a gradual increase in age. And again, we know that from the average, increase in age and the aging cohort effect amongst people who use drugs more broadly. We see disproportionately high levels of drug deaths in Indigenous people. That is getting worse. So it's always been bad, but it's a bad line going in a bad direction. We also see disproportionately high numbers amongst low socioeconomic groups. So amongst the poor and the disadvantaged, the numbers are bad. And this is true for all drugs except cocaine, interestingly. And when we come to kind of responses, I've said a couple of times in the media, I would hate to think that we're only going to sit up and take notice when kind of rich white kids that are so-called important start dying after accidentally, contamination in their cocaine supply, but we will see. And polydrug use also continues to be the norm. So there's some interesting kind of state stuff. So in my state of New South Wales, we've got worse overdose rates in regional and rural areas, and certainly in Victoria and Western Australia, they lead the way in terms of overall rates of death per head of population. And stimulant overdose deaths, I think, is really interesting because it's not what we often think about. We do know that there's a bit of an increase in use, but what we know is there's not massive new numbers of people taking stimulants, but the people that are taking stimulants are more likely to be running into problems, partly because it's a much more potent form of drug. We've moved from, powdered speed to crystal methamphetamine. And so we're seeing increasing, from other data, we know that we're seeing increasing harms, increasing presentations to emergency departments, and increasing overdose, which, is difficult to tease out. Raf might go into this, but presumably is often related to the impact of hypertension in terms of cardiac events and strokes. And I think we need to take notice of that, at least in part because our treatment system is very much focused on opiates. Now, I'm not trying to say we need to stop worrying about opiates, because that is not the case, but we need to be sophisticated in our response and understand that we're seeing a range of different issues in different communities, and we need to be able to pivot and respond appropriately and understand that all drug use doesn't have a withdrawal period of 7 to 10 days like we see for heroin. So what do we do with all of these numbers? I think it is beholden upon us, if we are going to the effort of tuning in and listening, whether live or in a, subsequent version of this podcast, if we're interested enough to be listening to this conversation, we've got to be prepared to do something about it. And what we do will be different for different people. But we have to combat stigma, and that's everybody's job. It might be that you think about the own language you use. It might be in conversations you gently pick up other people. It might be online when you see people making comments that you can go on, as a bit of a keyboard warrior and create space for a different narrative. You don't need to take people on and head down a rabbit hole of nastiness, but sometimes just creating space for a different narrative and allowing people to consider that a different way of talking about drugs and the people who use them is possible. So that's all of our business. We also need to take our democracy seriously and know that it is up to all of us to engage with our politicians. Because if I ask for people to put up their hand, how many people have not only written to, but phoned up or had a meeting with their MP, even in this presumably politically active group, I'd be willing to bet the numbers, I think, are probably going to be too small when it is policy that is getting in the way of evidence-based outcomes that will ultimately save lives. So you can pick up the phone and call your MP's office. You can write a letter, but you can also go and meet with them. And that, even in people with government jobs where it's harder, you have a role as a personal citizen, act on what you know. And I've, through my job, I've got to know a number of politicians, and every single one of them has said the same thing to me, which is, you'd be surprised, Marianne, how infrequently people pick up the phone. It makes a difference when they do. So we need to do that. We also need to, as a community, as a policy response, as a government response, as an NGO response, as a whole of sector response, we need to embrace harm reduction and embrace treatment, and stop accepting that the lion's share of funding goes to the interventions which have the least evidence of benefit, which is namely police and customs. Harm reduction receives 1.6% of overall drug funding in Australia. That is an abomination, and it needs to change. At the very least, wouldn't you, roughly speaking, if we talk about the three pillars of the approach, which is harm reduction, supply reduction, demand reduction, as a vague approach, wouldn't you think that then you would split the funding between those three pillars somewhat equally? No. Supply reduction gets 2/3. Demand reduction, which includes education and treatment, gets a bit less than 1/3, and harm reduction is barely a blip. Naloxone, a drug that couldn't harm anyone but will save a life. We have come a long way in recent years, and this is available probably in about 60% of pharmacies. It should be available in 100% of pharmacies. It should also be easy to get it when you go into that pharmacy. And I don't know how many of you guys have tried this. I've probably gone into at least a dozen pharmacies and said, hi, could I get some naloxone? Out of interest to see what the response is. And in all but one pharmacy, they didn't do it particularly well. My local pharmacy here in King's Cross is a master. Everywhere else, I've got a range of responses. I don't know what that drug is. I don't know why somebody, you would need it. You don't have a script, you need to pay money. All of us need to encourage our own local pharmacies to be stocking this. And we also need to be encouraging all services that are coming into contact with people who use drugs to have that immediately available in their first aid kit, and that includes police. I'm delighted to see police in Western Australia carrying the naloxone. That's been announced for Queensland. I would like to see that, occurring across the rest of the state. Supervised injecting facilities. We've seen the Victorian government, unfortunately, despite taking a policy of opening up a second injecting centre in the CBD, they took that to the last election only to drop it subsequently. Another supervised injecting facility doesn't need to be a political suicide mission. In New South Wales, for example, what we're really actively advocating is the notion that every time we give out syringes, it should not be illegal for us to be able to witness somebody using the equipment that we have just given them to use. Around Australia, I don't know how many of you on this call, how many of you know the number of syringes we give out? Have a wild guess in your mind and think about it. Add a zero, double it. It's more than 40 million. And yet there are two physical buildings in this country where people can actually use the equipment that has been provided to them, fully funded by government, because everywhere else it's illegal. That is a nonsense. And at the very least, we need to be able to allow needle syringe services, the existing harm reduction infrastructure that we have all around this country, to be able, where they've got space and capacity, to allow the injecting to occur on site. It's better for individuals, it's better for the local community. Everybody talks about education. Yes, we do need greater education and overall awareness about naloxone and the contaminated supply that we have, which is as bad as it's ever been. I put it to you that one of the best times to educate somebody about their drug use would be when they have drugs in their hot little hand and they're potentially seeking to use those drugs. And that would be drug checking. Why not, when somebody's purchased a drug that they're intent on using, why would we choose that moment to suddenly put our heads in the sand and flap about the provision of additional harm reduction and drug education in terms of engaging them, often for the very first time with a qualified health worker, about the impacts of drugs and what might be in the substances that they're using? We need to do a lot of stuff, and part of it is about making sure the left hand knows what the right hand doing, and I think we could, do better integrated care. We also need to, never forget, Maslow's hierarchy of needs. For example, where I work, often I think we're expected to work miracles with people who have polysubstance dependent, poorly treated mental health conditions, often schizophrenia and other significant conditions, and we're expected to, make them all better while they're living under a bridge. So we need a housing first approach, because nobody should ever be expected to improve their lives and their health if they don't have a safe space to be. So I think I will probably leave it there and hand over to Raf to make some more detailed comments about the numbers that she has so amazingly got in this report. But I would just remind her.
You've gone to mute, Marianne.
Click to mute. I haven't disappeared though, that's something. So I was just saying, numbers for numbers' sake and reports for reports' sake mean diddly squat unless we do something about them, because these numbers are unacceptably high. It doesn't have to be that way. It's not inevitable that it gets worse. It's not fair and it's not right that they continue to get worse, but they will unless something changes. And who is that something? It's us. And as we like to say at MSIC, if not us, then who? And if not now, then when?
Thanks very much. Thanks very much, Marianne. And apologies that I disappeared at the beginning, but that was a fantastic Cook's tour of the issues that we really are facing. And I had a message come up on my computer saying your internet is unstable, and I read it as you are unstable, because it's an emotional week. Actually, a lot of us have lost people to overdose, and they're deaths that don't need to happen. I think I don't know what Rafaela is going to include in her presentation, but one of the numbers that really struck me was 70,000 years of lives lost in the 1 year that this report covers. So thank you, Marianne. And now it is time to hear from Raffaella Caltabiano, who has done an enormous amount of work on this report with some assistance from Dr. Karen Gelb, who was presenting here last year. Raffaella is an absolute dynamo within the Penington Institute office, has an academic sort of background with a Masters of Criminology, but has also spent a lot of time in frontline service delivery roles in the forensic space, as well as in service coordination and leadership roles, and so comes with a wealth of experience. But this is her first annual overdose report, and I'm really looking forward to listening to this presentation, but a massive congrats to Raffaella. Over to you.
Thanks, John. I will just share my screen and we can start having a look at the numbers that you have both already given a preview to. Okay. Alrighty. As John mentioned, my name is Raffaella Caltabiano and I am a Senior Project Officer in the Research and Policy team. I would also like to acknowledge the Wurundjeri Boiwurrung people as the traditional custodians of the stolen lands on which I live and work. Penington Institute is a non-partisan organisation that focuses on supporting cost-effective approaches that maximise community health and safety in relation to drugs, including pharmaceuticals and alcohol. And this report is no different. So in this report, we do talk about both licit and illicit drugs, and we include alcohol as well to really get a full picture of what's happening in our community. Penington Institute is also the global convener of International Overdose Awareness Day, which is coming up this weekend on the 31st of August, and this year's theme is Together We Can. And I think that really reflects what Marianne was speaking about, that as a community we can come together to support each other in the ongoing grief for those whose lives have lost, for the ongoing harms experienced in the community in relation to drugs, but also to come together to take action and to support our communities to try and reduce the harms that we experienced. So Australia's Annual Overdose Report 2024 presents data from between 2002 and 2022. It does also provide a snapshot of non-fatal drug and alcohol related harms, and as I said, includes a full range of drugs, including alcohol. So in 2022, there were 2,356 drug-induced deaths recorded, and over 80% of these were unintentional, which is really a significant proportion. And so for that reason, I will be mainly focusing on unintentional deaths today. However, I acknowledge the report does also cover trends in relation to intentional overdose deaths. As John mentioned, this represents almost 70,000 years of potential life lost in 1 year, an average of 31 years per person. And since 2002, that is almost 40,000 overdose deaths that have been recorded, which is truly just an astonishing figure that is continuing to increase. So unintentional drug-induced deaths really affect everyone in our community. For the first time since 2002, the rate of unintentional drug-induced deaths is the same in metropolitan and regional areas when we look at the national data. And so I think it's really important to remember that when we're making policy decisions, that it really is everyone in all parts of our community. Having said that, there are some differences in who's affected by overdose in different ways. As in previous years, males accounted for 7 in 10 unintentional drug-induced deaths in 2022. As Marianne mentioned, Indigenous Australians continue to be overrepresented in unintentional drug-induced And this rate was actually on a downward trend in the early stages of our reporting period, so between 2002 and 2009. However, since 2009, it has increased significantly from 9.5 deaths per 100,000 population to 23.3 deaths per 100,000 population in 2022. And just as a point of comparison for non-Indigenous Australians, the rate has been much more stable over time, just rising from 4.1 deaths to 6.1 deaths per 100,000 population. When we look at jurisdictional differences, we do see some significant changes. Since 2002, there have been really noticeable increases in the rate of unintentional deaths in Western Australia, Victoria and South Australia. If we look at the blue line at the top of this graph, we can see that the rate of unintentional deaths in Western Australia has increased from 2.7 deaths in 2002 to 9.3 deaths per 100,000 population in 2022. And it has had the highest rate of unintentional drug-induced deaths since 2011. In recent years, though, the greatest increase has been observed in Victoria, where rates of unintentional drug-induced death have increased from 3.8 deaths in 2012 to 8.2 deaths per 100,000 population in 2022. Now, I will say these comparisons are stark, and there are many more in the report. So if you are looking for some more jurisdictional trends in relation to your local statistical area 3, so your local area data, there are some additional tables this year which show the top 10 regions in each state and territory in terms of their highest number of unintentional deaths and the drugs that were involved in those deaths. So if we do move on to thinking about which drugs are most commonly involved in these unintentional deaths, opioids continue to be the leading contributor. So in 2022, they were involved in almost half of all unintentional drug-induced deaths. The relative contribution of opioids has fluctuated over time from 41% in 2002 to a high of 61% in 2018, and that's dropped down again to 49.3% this year. We would expect to see that to rise without significant changes. Benzodiazepines, on the other hand, were involved in approximately 1/3 of unintentional drug-induced deaths in 2022, increasing from 18% in 2002. And in the benzodiazepine data, in the last 5 years, there were only 28 deaths involving benzodiazepines as the sole drug type, meaning that the vast majority of benzodiazepine deaths were all polysubstance deaths, which continues to be striking. As Marianne also mentioned, the largest increase that we have seen over time and we have seen in previous years is in relation to stimulant deaths, which were involved in 29% of unintentional deaths in 2022. As a point of comparison, in 2002, they were involved in just 6.3% of deaths. There are a smaller number, however, still significant number of deaths involving alcohol and antidepressants, which accounted for almost 1/5 of unintentional drug-induced deaths. If we look at this figure, we can also see that antipsychotics and cannabinoids were involved in a smaller proportion of deaths, as was cocaine. I do say cannabinoids here, we're referring predominantly to synthetic cannabinoids as opposed to natural cannabis. Finally, just to give a bit of picture of the way patterns of opioid deaths are changing, despite it being the leading contributor to unintentional deaths for a number of years. In particular, heroin is the number of unintentional deaths involving heroin continues to be the most prominent in the data. However, if we look at the last 3 years, we can see some variation. So in 2021, the number of heroin deaths decreased significantly before increasing to the same level in 2022 to 460 deaths. Now, the report does not necessarily isn't necessarily able to say why this is. However, we do know over this period, drug market shifts as a result of COVID-19 took place. And so we see significant variation in heroin-related deaths there. Oops, I've gone too far, my apologies. In comparison, we are able to distinguish some opioid-related deaths into semi-synthetic and synthetic opioid categories. So we see here deaths involving opioids such as oxycodone, morphine, and codeine are actually showing a downward trend after peaking in about 2016. And this may be in line with changes in terms of prescribing practices and rescheduling of codeine in 2018, but it now stands as a significant decrease compared to the trend earlier in the reporting period. By contrast, opioid deaths involving fentanyl, pethidine, and tramadol, among other pharmaceutical opioids, have increased substantially since 2002. However, still form a small portion of opioid-related deaths when compared to heroin. Now, I will say, due to the process of coding determinative death data, data from 2001 and 2002 will be revised in the coming years. And so we do expect that some of these figures increase about 12% each year. And so that's the dotted line in this graph. And so with that in mind, it is sobering to consider that these 460 heroin deaths may even increase without further action from our community. And so with that, I will say thank you for your time. There is significant further breakdown of each drug type and their trends in the report, which can be downloaded from our website. And if you do have any further questions about the data or what we can and can't provide, my email address is there and I'd be happy to assist. Thank you.
Thanks very much, Raf. That was a very fast tour through something that takes months to put together and is about an inch thick. So an amazing summary job. Thank you. Just wanted to remind people, if they've got questions, to please put them in the chat. There's a few that have been asked already, and I guess this might be one for you, Marianne, which is the question has come through: what has the impact of real-time prescription monitoring been so far? And I wonder if you could expand on that and just reflect on that approach of real-time prescription monitoring in the context of the overdose toll.
So the issue of supply is a vexed one, because we know that the more readily available and access to substances there is, you can see an increase in use. If something is really readily available, whether that's cigarettes and alcohol or other substances, you can see an increase in use. An increase in use can lead to an increase in harms. But we also know that if you try and clamp down on that supply too hard, for example, by criminalising and stigmatising something, that the harms go up as well. So real-time prescription monitoring is trying to provide a balanced way so that medicos have got access to what other prescriptions are have been made recently for someone, and so they ideally have a much better indication of whether the person in front of them has potentially problematic drug use, and ideally is making, safer choices. Susie Nielsen's done some fascinating work. I don't know whether she's online, but the thing that we don't want to do and the trend that we don't want to follow is what's happened in the United States, where we saw massive over-prescribing of opioids and a considered effort to try and pull that back, but probably clamping down too hard such that the overdose deaths continued and people shifted from prescription opiates to illicit opiates, specifically heroin, and now more recently from heroin to things like fentanyl. And, the scale of the overdose toll across North America and the United States and Canada, it could not be overestimated if you tried. It's absolutely horrifying. Life expectancy for a middle-aged white man has gone backwards, I understand, for the first time outside of a war period, because of the sheer numbers of overdose deaths. People aren't even attempting to buy heroin in a lot of places. It's just fentanyl that they're going. So it's a two-edged sword. People have probably seen that U-shaped curve where we don't want to have a very criminalised strict market, but we don't really want to have an unregulated legal market without any controls either. And we're trying to look for that sweet spot in the middle. You talked about towards zero, John, and I think that's right. I don't think a realistic goal is to have zero overdose deaths, but we can do a hell of a lot better than we're doing at the moment. A hell of a lot better.
Thanks, Marianne. And do you think that the increase in heroin-related overdoses might be related to the sort of reduction in access to pharmaceutical opioids?
So I think that's a concern. I mean, certainly, in 2000 or so, when we saw the end of a glut, and sometimes it's called the heroin shortage, sometimes it was the end of a glut. We've been coming off a low base, so there really wasn't anywhere to go other than up from there. And certainly I think in COVID, that magnificent graph that you showed, Raf, with, the heroin kind of really going down over COVID, I think there's no question other than that was decreased access and decreased supply. But, what we've seen in the States is that if you push down too hard, you do get it popping up in other forms. So I think that the increasing numbers in heroin is something that we should be concerned about. And I think the contamination of the drug supply, like across Australia, not just in my state, New South Wales, the number of drug alerts is at an all-time high. And, the nitazene numbers are not high, but they appear to be going up. And the numbers that we've got, in terms of, if you look at published literature, it's clearly an underestimate because of this delay that we have in terms of getting the data out of coroner's reports, which is why you've got to do a deep dive into the National Coronial Information System. And a lot of that work that is being done shows us a different picture. So I think it's concerning because I think it appears that, the only way is up.
Thanks. And just to follow on from that in relation to nitazenes, there's a couple of questions here in relation to nitazenes. And I guess, the first one is how many deaths involving nitazenes have we had in Australia, and when was the first? Are you experiencing clients using nitazenes, and if so, related overdoses? Is naloxone effective for nitazene overdoses, and are extra doses required?
Right, I think that's 5 questions rather than 1. But the whistle-stop tour of nitazenes, these are lab-grown synthetic opioids, which are crazy strong, often an order of magnitude more potent than family of fentanyls, but it is a range of substances. They were originally manufactured, I think, in the 1950s and quickly put aside because the margin between a therapeutic dose and a fatal dose is kind of wafer thin. So they were immediately discarded as having any kind of therapeutic use. And we've just really started to see them in Australia since about 2021. We don't know what the numbers of deaths are. I think there's something that's been published recently, but it's an underestimate. We know from the coroners in Victoria, I think that there was a statement that there'd been 16 just in Victoria, and a question about the 4 very public deaths. There was a lot of media story earlier this year about 4 deaths in a house in Broadmeadow that were likely to be very potent synthetic opioids and possibly / probably nitazenes. And, you know, we've been contacted by people in a number of different other states after we've done media. And, you know, when I've said we don't know the number, and people have written in and said, you know, my sister, my brother was one of those numbers. So the problem is that death data is too slow. And so we have to rely on other things to give us trends and to get concerned. In terms of naloxone is a fantastic drug, and everybody needs to know what it looks like, how to use it, that there's a nasal spray called Nixoid. It doesn't have a needle in it. It's not frightening. It's preloaded. It's got 1 dose per device. Don't try and, you know, spray it in the air to check that it's working. Just shove it up somebody's nose to give that first spray. And yes, it absolutely does work with nitazenes, but there is definitely evidence to show that people potentially need longer and so more a total increase in the number of doses and potentially the length of time that they need to be maintained on naloxone. So the general rule of thumb is absolutely know how to recognise an overdose, slow breathing, turning blue, reduced level of consciousness, absolutely have naloxone on hand, but also don't hesitate to call an ambulance.
Yeah, thanks, Marianne. And maybe it might be just worth noting.
John, do we say, is he unstable? It's anyone's guess. What it might be worth noting. What a wonderful time for him to cut out.
Am I?
You're back.
Great. Can I just sort of cross-promote, I guess, in a way, which is that I think on the Penington Institute website, people will find a seminar that we did on nitazenes a couple of weeks ago, which included one Australian expert from an emergency department context, but also more importantly, I think for us in Australia to learn from the experience internationally. So we had a speaker from Dublin in Ireland, where they've been facing this problem for longer than we have, and also one from England where they're similarly facing this problem. And it does seem, I don't know if it's true or not, but it seems to be the case that part of the uptick in nitazene availability, which similar to fentanyl is mostly manufactured in China or in the environs of China, but it seems to have picked up after the Taliban clamped down on heroin production in Afghanistan. And so to my mind, it really reinforces the global nature of the drug supply that we're experiencing in Australia, and also how something in one country can have a big impact on another. And some of the nitazenes are definitely coming to Australia from the United Kingdom, which is not a traditional drug trafficking route, but it's something that we're now having to face up to. Apologies for my tech issues. Raf, I might throw the question to you, which came in around what are the sources for your data collection to generate this report? And if you can, to talk a little bit about the stimulant overdose data.
Absolutely. So the majority of the data in the report are from a customised data request from the ABS. So the ABS collate mortality data from all coronial investigations throughout Australia, and then that goes through a rigorous coding process. So that informs the majority of our data in relation to intentional and unintentional deaths, including the polydrug use data. That is also supplemented with data in relation to non-fatal harms, which is via the ABS and our colleagues at Turning Point, as well as some additional contextual data in relation to published research and some de-identified case studies that are from the National Coronial Information System as well. In relation to stimulant deaths, I did mention that we've had a significant increase in stimulant deaths in the reporting period. The stimulant category does include methamphetamines, amphetamines, and MDMA. So it is a relatively broad category, but we're unable to sort of disaggregate the way we are the opioid category, which I spoke through. The number of unintentional deaths have increased significantly, as well as their presence in polysubstance deaths. So in the last 5 years, only 20% of stimulant-related deaths were solely stimulant-related, and the remaining portion were all polysubstance deaths. So similar to benzodiazepines, we're seeing them being involved where people are have 2 or more drugs in their system. Yes, thanks, John.
Thank you. And
just a quick point, I would say, like you mentioned, Raf, that you can't kind of within the stimulant deaths, it could be speed or methamphetamine or MDMA. We certainly know from other work that's been done that the number of total MDMA deaths is not high. So I think it's fair to say that the majority of those stimulant deaths we're talking about is going to be related largely to methamphetamine use.
That's very true. And Marianne, what about GHB? It's something that is really another part of the sort of evolving nature of drugs in our community. Have you got any sense of the stats in relation to GHB, or more particularly, I guess, according to the question, how does one help someone who is overdosed on GHB?
So we don't see a lot of G at MSIC in King's Cross. Occasionally we do. And I suppose it goes to the nature of different people in different cohorts often use different types of drugs. So in terms of overall numbers, I couldn't give you any answers, but often what you'll see with a G overdose is that you need supportive care. So again, it goes to why it's really important that you make sure that you are calling an ambulance for someone and not just relying on the fact that naloxone on its own might make a difference. So you're looking at supportive care, which might involve a period of time in hospital and potentially maintaining someone's breathing and keeping them calm.
Thanks. We've sort of skirted this issue, but there's a question coming in relation to prisons, and specifically the question is, do you think lobbying politicians will assist to improve access to Nixoid or naloxone or Buvidal on discharge from prison? And I guess some reflections on the way that the prison system interfaces with the health system is a really tricky and important area of neglect.
It is, when you consider that, you know, the theory is that people are in prison and it's the removal of their liberty, which is supposed to be the punishment, not lack of access to appropriate healthcare. So they are supposed to get equivalent healthcare in prison as outside prison. The removal of liberty is their punishment, not anything else. So that, you know, we can't say we're not going to treat you as part of your punishment. That is not the way the prison system is supposed to work. And yet, who fills our prisons but people with drug-related issues, including polysubstance dependence, and who is more likely to die in the first 2 weeks of leaving prison other than our folk. So it is an absolute huge area of unmet need, and it's unfortunately one of these areas that is considered a political hot potato, and people just put it in the too hard basket. So other than finding a way of engaging with politicians and changing the public narrative and the discourse around that, I don't have any other suggestions for how we do it. It is going to be a long, hard road, and a lot of people need to make a lot of fuss over a long period of time in order to create the space where politicians feel that they're able to change. And it's hard enough to treat people who use drugs fairly and with dignity and appropriately, let alone someone who's also committed a crime such that they're in prison. Not the way it should be, but the way it is, unfortunately.
Raf, have you got reflections on this?
No, except to say from a data perspective, you know, it's another area that we would like to be able to have some more information on. There are some great research projects taking place in relation to people's health needs being met while in prison, but definitely it would be, it would colour our picture more thoroughly if we had that data available.
And
Can I make one quick comment? There's something just about COVID, and I was just, one of the things in terms of the lessons from COVID, which you guys might have other reflections, but to me, it was actually a beautiful example of when we need to, we can get shit done. You know, necessity is the mother of all invention. We did extraordinary things over COVID. We suddenly increased the number of takeaways. We rolled out, you know, buprenorphine at a rate and a pace that would have been unheard of without the necessity of a pandemic breathing down our necks. And you've got a graph, you know, did the number of methadone deaths increase? No, they did not. You know, so I do think there's some lessons in there about being prepared to be innovative and push for significant change, because when we needed to, we got a great amount of stuff done because we had to.
Spoken like a real Sydney person, because the experience in, I mean, we did actually do a lot of good things in Victoria in relation to access, particularly to OST, and keeping needle and syringe programs open during that period. But generally, I think our lockdown experience in Melbourne is something that we all really want to forget. So it's good to actually get some lessons out of it and then not
Fair point, John.
the rest. Just sort of speaking of that, one of the speaking of the custodial system, we think about prison officers and whether or not they should be carrying naloxone, whether the people who are incarcerated should be able to access naloxone within custodial settings or indeed on release. But what about police? There's a shift internationally, I think, in relation to police carrying naloxone. We've seen it in WA. There's been a shift in Queensland as well. What's happening in New South Wales, Marianne?
Very little. So as people will know, we've got a drug summit coming up. So we've got 2 days in regional New South Wales, yet to be announced where in October, and then 2 days in early December, the 4th and the 5th of December. And I think it has to be something that we have on the radar. I think my sense is that the police have got a sense of, oh, you know, it's too hard. We carry a lot of things. You know, are you expecting us to be ambos? And I suppose our response needs to, you know, we need to understand, you know, what is making it hard and reduce the barriers where we can for police. But I suppose my response is, well, you know, I don't think we're asking you to be ambulance officers, because we're not asking you to turn up, you know, and you don't normally turn up to asthma attacks and, you know, cases of you know, allergic reaction and anaphylaxis. But we do see you more often than not as an overall emergency response in overdoses. And why would we not give them access to a life-saving drug that can do no harm? I remember in the early days of MSIC, one of the things, the reasons that we had such incredible support from police, and so we've got, you know, police as well as health overseeing our licence and supporting our operation. And speaking to a lot of the local area commanders, they were saying, my officers have got PTSD because they've found too many cold, dead blue bodies and had to call the next of kin. So I don't think we should underestimate the impact of overdose and that emotional toll on all frontline services, and actually that includes police. So a lot of the frontline police that I've spoken to are absolutely supportive. I suppose we just have to, you know, work through what some of those barriers are, work out if they're perceived barriers, and if we can help shift that narrative, because I certainly would be, especially as we're potentially seeing increased heroin, increased nitazenes, and increased quite potentially rapid death with the very synthetic opioids. It needs to be something that whoever is there first absolutely has on hand.
Yeah, and I think that's really real, that burden on police, and even going to the family to advise of someone's passed. but it is hard to get the command, you know, the top brass or whatever to understand that. I think I can remember making that argument actually directly to a chief commissioner, and the response was very dismissive, and it included, they see lots of bad things, so this is like, you know, it's trivial compared to everything else, which I think is very unfair and untrue, and reflects a kind of desire not to make any change. We do have a pretty conservative frame in Australia when we think about these issues. In fact, I think we're still pretty much stuck where we were 40 years ago or whatever in the way that we think about drug problems. So it's definitely a challenge, and I think persistence is the only, well, a lack of persistence is the only failure. We've just got to keep plugging away, because we do have improvements, and the 2 consumption rooms are a big improvement. Drug checking is expanding, and I think that's a big improvement. So, you know, in the long term, we do get improvements. Unfortunately, too many people die in the meantime. I'm just conscious of time, so I want to give an opportunity to you both for any last comments before we wrap up. Marianne, do you have any last comments?
I suppose, you know, I'm incredibly lucky to work within an organisation, not just MSIC, but the broader Uniting, which is part of the Uniting Church, that advocates for drug law reform and an increased investment in treatment, knowing that those 2 things are what together is going to make a difference. And sometimes I think people think, oh, well, it's too hard. I work for a government department, or I work for this organisation. But if you can work out what your sphere of influence is, it might be within work, it might be within your family, it might be within extended colleagues, it might be within a church group or another group that you do. Because, you know, we're only going to fix this one conversation at a time, but it takes us doing something differently, because if you don't do stuff differently, we're just going to get what we've always got.
Yeah. Thanks, Marianne. Raf?
Well, I'd just like to say thank you for engaging with the report so thoroughly, and I hope that it can be useful in that advocacy in your community, in your work, in whatever way is helpful to you. And if there are things you'd like to see in the report in future, or things that would be helpful in that endeavour, please get in touch, and we'll see what we can do.
Yeah, good point. Thank you. And yeah, thank you very much to both of you. And it's been an interesting, certainly for my ears, it's been an interesting conversation, and apologies for my tech issues. Just sort of, I guess, bouncing off Marianne's comments, part of this week for us is International Overdose Awareness Day. So I'd like to thank those of you out there who are running events. Our model is very much about exactly what Marianne just described, which is about people taking the opportunity in their own context to push forward. We don't really determine what people do at the local level. The whole idea is that you drive it yourself according to what priorities you believe to be the priority. But it comes up this Saturday. People are doing events during the week, and we'll do some next week as well. And so if you're not doing anything this year, I'd encourage you to participate one way or another, including through social media. And next year, I think with a 12-month lead time, I really encourage people to step up. It is a way of having conversations around overdose that are not stigmatizing and not only respectful of people that are lost, but also ambitious in terms of preventing overdoses in the future. That's the spirit of International Overdose Awareness Day. But today's about the overdose report. So thank you very much, Marianne, for your contribution, and thanks very much, Raf, for your long months of toil and your contribution today. And thanks also for everyone joining us. I hope you found it helpful, and I hope you have a great rest of the day. Thanks all.